Hello and welcome to our Q&A video about the COVID-19 vaccines. The date of this recording is Thursday, the 14th of January 2021. I'm David McMahon, the Chief Executive with the Irish Skin Foundation, and I'm joined today by Professor Anne-Marie Tobin, Consultant Dermatologist, Pharmacist, and the HSE's Clinical Lead in Dermatology. Hello, Anne-Marie.
Morning, David. How are you?
Very good, thank you. Very good. Hope you're well too. So the vaccines are now being offered. In fact, the government has today said that it hopes to vaccinate up to 4 million people in Ireland by the end of September. But they're brand new. People have a lot of questions about them. So this video, which is, as I said, in a Q&A format, aims to address some of the concerns which people living with skin conditions might have, and but in particular questions that people who may be taking immunosuppressive drugs may have. So just before we begin, vaccinating the population, widely, because I suppose we're really only beginning with healthcare professionals at the moment, and some people living in care homes. What are your thoughts about the vaccine in general?
So, David, you're speaking to the converted because I was vaccinated last week. So I received my first dose of the vaccine. And to be quite honest with you, it's an incredibly good news story in the midst of all the COVID, and for a number of reasons. One, because it's so effective. It's 95% effective. And secondly, because the drug companies are actually making it available at no just a cost. So the Moderna one is for profit, but the others aren't. So it's a very good news story. So going back to your point that they've started off with healthcare workers and also in the nursing homes. So to put that in context, in Tallaght Hospital, where I work, we've already vaccinated 2,700 people. So now the government is going to look at the next tranche of people to be vaccinated. And I predict that these will be the over 65s with a comorbid condition, so or elderly people living in the community, because not all elderly people receive care in nursing homes. And then they will look at patients who are less or younger than 65 with a comorbid condition. And I predict that this will include our patients who are on immunosuppressants. So, for example, psoriasis patients receiving biologics or methotrexate, eczema patients receiving azathioprine or methotrexate. So I predict that our dermatology patients will be in that group.
So they're in the group of people that are directly after the over 65s.
Yes, I'm hoping that that's where they will be, that they will be prioritized. It's not clear yet. The government has really only identified frontline care workers and nursing home residents, but they're in discussions at the moment about who the next groups are.
Okay, and I suppose we just have to keep an eye on how the allocations sort of begin to pan out in reality over the next few weeks and months to see exactly how people will fit in.
Yes, no, exactly. Yeah.
Okay, and I suppose one of the things that has been in a lot of the coverage about the vaccines, particularly since they started really becoming a reality since the end of November, is the level of immunity that the different vaccines offer. That what does it mean? What does immunity mean? Like, what is immune, and how long will it take before someone who is offered the vaccine is immune?
Okay, so maybe just to give a little brief overview about vaccines. So vaccines are where you give a small, well, there's three types of vaccines. So one is you can have vaccines that are what's known as protein subunit, and they have a tiny little part of the microbe or the virus, and they're injected in, and it's designed to sort of waken up your immune system, but not give you the full-blown condition. For example, not give you polio. So there's two arms to your immune system. You have B cells, and these are white blood cells that are in your blood, and they produce antibodies. So they're the immediate kind of arm. But then you have the second type of immune cells called T cells. And these are a certain proportion of these cells are what's known as memory T cells. And these are what you're wanting with vaccination. So these T cells stay in your immune system. They're known as memory T cells, and they recognize if you come in contact with the disease again, and they are what gives you immunity. So you have your protein subunit vaccines, and then you have what's known as vector vaccines. So these are where the vaccines are linked to a certain type of delivery. But then you have these new vaccines which fall into the COVID, of which the COVID vaccine is one. And to be quite honest with you, patients are going to be partaking in history because these are a new type of vaccine. And not only are they going to be phenomenal for COVID, but there's likely that the technology produced in them offers hope. For example, you could vaccine against cancers. It's just so exciting what has occurred with the development of these vaccines. So these are known as microRNA vaccines. And what it does, I beg your pardon, messenger RNA vaccines. So what it does is they are these tiny little molecules which are injected into you. They go into your cells and they tell the cells to produce. So they're like programming your cells to produce the antibody response. And then that messenger RNA is destroyed itself. So they're an entirely new way of vaccinating. But a couple of things about the vaccine, David. So one is all our patients who are on immunosuppressants will be familiar with getting, for example, the likes of the flu and the pneumonia vaccination. So the vaccine is inactivated. So it is safe to get when you are on immunosuppressants, because patients will have been warned not to get live vaccines. So it is not a live vaccine. So it is safe to get when you are on immunosuppression.
Okay, so this is a completely new category of vaccine that we've never had before, and is a big advance scientifically in terms of what would have been, say, available 5 years ago or 10 years ago.
Hugely so. Hugely
Okay.
so. It's a very exciting time, and it's a tribute to science that we have come up with these vaccines in such a short space of time.
And I suppose it's fair to say as well that the more people that are vaccinated, like the better benefit it is for everybody, for society at large, and that I suppose you would hope as a follow-on from that would mean that we can begin to get back to something like normal life in the last, I suppose, the second half of the year, or the last quarter of the year at least.
And so when you're talking about vaccination programs, you're referring to what's known as herd immunity. So people be familiar with all of the discussion around, for example, herd immunity in the UK. And in fact, that was completely the wrong context in which to discuss herd immunity. Herd immunity refers to vaccination, not to do with the outbreak. And we need to get 70% of the population vaccinated to suppress the virus within the community. So not only are you helping yourself by getting vaccinated, you're also helping the community in general. And it's really our only hope of suppressing the virus, because it has become the outbreak has just become so widespread, not only in Ireland, but actually internationally. So the vaccine is kind of our only hope.
Turning then just specifically to, in relation to kind of people who are living with psoriasis or eczema or HS, just to take examples of 3 skin conditions, there have been some concerns among people who are on biologic or systemic therapies. You know, at the beginning of the COVID-19 outbreak, you know, I suppose nearly a year later, like, has research shed any light on their, I suppose, vulnerability or susceptibility to COVID-19? And does that tell us anything about, you know, the vaccine? Does that have any impact? Is there anything specific that we need to highlight for people with those conditions now?
So going back to the impact of COVID in patients who are on immunosuppressant, what we've seen from the data, and it's not purely from just dermatology patients, but also from patients who are on similar medications for arthritis and for inflammatory bowel disease. So those patients who are on a biologic who did get COVID seem to have done a little bit better, in fact, than those patients who weren't. So it would appear the theory or the thinking behind it is that being on that immunosuppressant actually dampened down that huge inflammatory response to the COVID virus. And it's actually the inflammatory response is what is causing a huge amount of the illness with COVID. So that was very reassuring for us, because now we're a lot more comfortable about our patients continuing their treatment and even starting patients on new treatments during COVID. But we are recommending that the patients do get vaccinated despite this. We are also recommending that the patients follow the guidelines, washing hands, social distancing, and wearing masks. It doesn't change that. And going back to your early comment, I don't want to be too depressing, but I think we will still have precautions in place up to the end of the year.
Okay, well, that's, yeah, because I suppose until we reach that, you know, that 70% or so, surpass that 70%, we really, you know, we can't be complacent about people picking up the infection. And just to follow on that from my last question, so if you are immune suppressed, so taking an immunosuppressive therapy at present, are there any, does that have any impact on mounting an immune response when you take the vaccine?
That's a really good question. And to our knowledge, we don't think so, because our patients get vaccinated with the flu vaccine every year. The only group that we have a little bit of concern about would be patients on high-dose steroids, which fortunately aren't a lot of our patients, and possibly patients who are on a medication called rituximab, which again is very, very few. But I think we don't expect, we expect patients on immunosuppressants to mount a suitable response.
Actually, would you mind repeating the name of that last drug, because we had a small interference with sound briefly.
Oh, I beg your pardon. It's rituximab. It's very, very rarely used, but it basically targets B cells and takes out your antibodies. But in fact, we don't know. They would be just the two that we would be asking questions about, but we will be vaccinating those patients.
Okay, so that is basically then for the vast majority of people who are taking who are on an immunosuppressive therapy, they can receive the vaccine pretty much at any point in their treatment. That's not.
Oh,
that's
very
not
yes.
Okay, okay. And that's you've sort of answered my next question, because I was going to ask about any other medications, but you've kind of addressed that now. So that's good to know. You know, in relation to you know, the actual, you know, getting the vaccine itself, when people are offered the vaccine, or they receive a letter or a text, or I don't know how it's going to be done for the general public, they'll come into a centre to get the vaccine, and they are going to receive it in the upper arm, and there are, as far as I know, it's a two-shot schedule. Is there any, what's the reason for that, or is that normal with vaccines?
So with regard to the COVID vaccine, you will get a notification to attend a centre, and you should attend. And at that, you will fill out a questionnaire and also a consent form. And the questionnaire consists of whether or not you might have had COVID in the previous 14 days. Because they won't give it to you if you have a current COVID infection, and that makes sense. So you fill out a short health questionnaire and a consent form. The vaccine is then administered. It's a tiny vial. Actually, you'd be shocked at the size of the vial. I got the Pfizer BioNTech vaccine, and it's given into your upper arm. And I had it in my left arm because it's my non-dominant arm. And to quite honest with you, the injection was much less painful than the flu vaccination, which I get every year. And then you are, so first of all, the HSE have produced very nice booklets about the vaccine. So you'll get one of these and all the information is in it. You are then given a card like this. And this card is going to be, I think, really important because I think it's going to be my passport to travel or go on holidays. So this is your vaccination record card. And you are then scheduled to receive the second dose of the vaccine. Now, what we know, in fact, is, and what recent studies have shown, is that, for example, the vaccine I got was thought to give me 70% immunity from the first shot, but they think that that is a lot higher. But the trials that were done on the vaccine were on 2 doses given 3 weeks apart. And 1 week after receiving the second dose, you're 95% immune. Now, it's very common to get second doses of vaccines. Patients won't be familiar with it from the flu and pneumovax because they are isolated, but it's very, for example, if we consider the vaccine for HPV, the Gardasil vaccine, that's actually 3-dose regimen. So the dosing schedule is not uncommon.
And so 95% immunity after the second shot, after, of course, that's a few weeks after the second shot.
No, 1 week.
1 week. Okay, yeah. Very good, very good. Okay, so a few things to note there. That's a really high level of immunity. Mm-hmm. The card, as in that's something that you want to really be careful about, hang on to.
Yes.
If you've any aspiration to go abroad or try to get away for later in the year or early next year, that's going to be needed. And the other thing, I suppose, we've now, at the end of last year, we all got a huge shock because of these new strains that are coming out, particularly the one that was identified in Britain, and then the other one that was identified down in South Africa, both of which we know are here to a higher degree or a lesser degree. Do we know anything about how the current vaccines that are available now, do they cover or do they protect against those new strains?
The one that has had the most kind of data about it is the Pfizer BioNTech vaccine, and they do cover, and it's also believed, but I don't think that the formal studies have been done, but they do think the vaccines do cover the new variants as well. Certainly the UK variant, and they think as well the South African. With regards to the clinics, the face-to-face appointments for example, patients who are on biologics or medication, they are being cancelled, but it's only the face-to-face component is being cancelled. So, for example, in my department, we're ringing patients, and if they're in trouble, we will actually see them. So the clinics are moving, I wouldn't say they're cancelled more, they're moving to a virtual platform. So that's one thing. The second thing is just to be careful. You do not want to end up in hospital, for any reason, never mind COVID, but you don't want to end up going into the hospitals at the moment because it's not pretty. So keep washing your hands, keep social distancing. I mean, one of the things that slightly worries me this time around is this lockdown feels very different to the first lockdown. There's a lot more people out. There's a lot more traffic on the roads when you compare it to the first. You just stay home. Stay home. It's probably only going to be another 2 to 3 weeks. Hunker down, and really make sure that you're in the queue for that vaccine. So I mentioned above, what we've seen is that, for example, most of the patients on biologics have not had a worse outcome. So anyone who has stopped their medication, we've recommenced it. So all of the patients for whom, because we didn't know at the beginning of the year, that was the issue. This was an entirely new virus. But any of the patients who would have stopped would by this stage have been seen by their clinician or their dermatologist. But I wouldn't advise anyone to stop their medication. I would advise them to keep going. And that is the advice that we are, we're not stopping medication, or certainly not stopping biologics, but really just for the next couple of weeks, wash your hands, wear your face mask, stay at home.
Okay, Anne-Marie, thank you very much for answering those questions and for giving us some advice about the vaccines and what we can expect over the next few months. If you know, I suppose we always say stay tuned to irishskin.ie, and we'll keep updating our information on our website, on Facebook, and on Twitter. And as Anne-Marie said, the HSE has published a leaflet, and there's a really good web page as well that they have they put together. I think it first appeared on Tuesday. We'll put a link to that underneath this video, and we'd encourage everybody to visit that when they get an opportunity. Thank you very much.